That's great.
Good morning, everyone. I know that the coffee is still settling, but we are going to go ahead and get started with the open plenary session of the National Minority Equality Forum. My name is Marvin Figueroa. I am a senior lecturer, visiting professor at Meharry Medical College, and I have the distinct honor of moderating today's conversation. And let me tell you that today's conversation couldn't be more timely. Across the country, state houses right now are debating the future of Medicaid, whether or not it's responsive to the needs of their population, and equally important, whether or not it's sustainable. Here in Washington, D.C., we have this thing called budget reconciliation, which I say is a budget fight about our morals and who do we care for and who do we care about in this country. That conversation is unsettling for many, because a lot is at stake in terms of Medicaid and its ability to take care of the least amongst us, but also a lot more than that, right? That's a big misunderstanding about Medicaid that we'll correct today. We're also going to talk about the marketplace. Another challenge is looming. Unless Congress acts, the enhanced tax credits that have made ACA coverage affordable may go away. Without action, premiums could spike, putting coverage out of the reach of many working families. In this moment, engagement is critical. And we're here not only to describe the landscape, but our goal is to also provide the information that allows you all to shape it. So here's a couple of things we're going to accomplish this morning. We're going to talk about Medicaid in the marketplace. Where is it? What are the challenges? And what can we do to make sure that we are active? We will talk about misunderstandings that we need to clarify so that we have the most accurate information when we're advocating. And we're also, more importantly, going to ensure that you all have what you need so that policy decisions don't widen the gap in coverage, but help folks cut that disparity in access and care. To answer these questions, I am joined by an incredible group of panelists. We have Lauren Aronson, is the executive director of the Keeps America Covered Coalition, where she champions efforts to protect and expand coverage through Medicaid and the ACA marketplace. We have Dr. Carrie Cochran-McClain, Chief Policy Officer at the National Rural Health Association. She brings expertise on how Medicaid and marketplace impact our rural communities, and what it means for patients on the ground. We have Craig Kennedy. He serves as the CEO of Medicaid Health Plans of America, representing health plans that serve Medicaid beneficiaries across the country. And we have Dr. Parinda, Khatri, CEO of Cherokee Health Systems. She leads one of the nation's most innovative integrated healthcare models, particularly focused on reaching the underserved populations. Folks, help me welcome our distinguished panelists. I should have had y'all wave so people know who's who, but we'll figure that out. We know who Craig is, huh? Craig, we're going to start off with you. Okay. One of the things that I wanted to make sure that happened in this conversation is that people had a sense of what is Medicaid. I know that Medicaid touches lives very differently, and folks know what Medicaid is generally. But tell us, what is Medicaid? Who does it cover? And any interesting facts that people should know as they think about Medicaid and put that in their brain.
Well, first of all, good morning. I know. Kind of expected like those blinds to come down, like the sun to come in instead of these bright lights, but that would be awesome. So anyway, I'm Craig Kennedy. I'm with the Medicaid Health Plans of America. I've been here about 5 years. Before that, with Clinicians for the Underserved, and before that with community health centers. And so a long history of working with NMQF, as a matter of fact. Where did Dr. Puckrin go? Anyway, so thank you very much. I really appreciate being here and appreciate the question. So let's just start with Medicaid. So I know you guys are all familiar with the concept of Medicaid, but it's extremely expansive. It's not one thing. It's not, Medicaid populations in this country. It's not the one thing. It's not one thing. You can't talk about it and just say, Medicaid. It is 40%. We cover 40% of all births in this country. We cover 60% of all nursing home care. One side of life, the other side of life. We cover 60% of Medicaid population. 80 million people, 79 and change. 80 million people are on Medicaid today, are insured through the Medicaid program. About 80 million people. So a big swath of America, about 1 in 5 people, are in are insured through the Medicaid program today. So 80 million people, about half of all births, about half of all nursing home care in this country. We also cover, we're the largest payer for substance use, mental health care in the country, cover foster children, cover justice-involved populations. So a diversity of people are insured through Medicaid. Age, blind, disabled is the traditional populations that people think of where Medicaid started, age, blind, disabled. But it's so much more than that. It's such a wide range of folks across the country. And so it's a diverse population. And so that's Medicaid in a nutshell.
Yep.
I can go into kind of the structure if you.
I was in Connecticut a couple of days ago, and they had Husky Care. And when I used to work for California, it was Medi-Cal.
Medi-Cal, exactly.
What's the difference?
So every single state runs it differently. So Medicaid is a federal-state partnership. So you heard even from this morning about the federal role within the Medicaid program, which is most of it. The federal government mostly funds the Medicaid program. They are the largest funder of the Medicaid program. But states also put in a portion. They have a matching percentage. Every state is different, but it has a matching percentage of their Medicaid program. And every single state is empowered to run their program differently. So the federal government mostly funds it, but the states run it. So all of the states have a different Medicaid program and run it differently. Most states, 43 now, Idaho just came into the fold, most states run it through managed care companies, my members. So the members of MHPA, Medicaid Health Plans of America, the health plans that are members of ours, run the programs in conjunction with the state. The state contracts, 43 different states, contract with private plans, and those can be for-profit, nonprofit, single state, multi-state. They can be a whole range of things. The state gets to determine how they're going to do it. But they're run, every single state is differently. You mentioned California. Digress. California is practically run at the county level. It's not just run at the state level. So you have to go all the way down to the county level in California to determine what your Medi-Cal plan is named within California. So they name them different, they run them different, but it's mostly funded by the federal government, but run by the states.
Great, thank you for that. Lauren, I'm going to turn to you for the marketplace. It sounds very abstract. And I think as part of the Affordable Care Act, it used to be called Obamacare until it started working. Can you give us a sense of what the marketplace is, what trends are we noticing and seeing, and what are the challenges ahead?
Great, thank you. Thanks for the question, Marvin, and thank you for having me. I'm very honored to be on this panel and in front of all of you this morning, and I'm glad everybody is caffeinated. So I'll just do quick 30 seconds about our coalition. So Keep Americans Covered is a coalition of patients, consumers, hospitals, physicians, rural healthcare, really just working to ensure that the marketplace can continue to thrive and grow for the 24 million people who rely on it. So as Marvin noted, people can call it many different things. Obamacare, the Affordable Care Act marketplace, and traditionally known as the individual health insurance marketplace. So people purchase their coverage in different ways. And through the Affordable Care Act, millions of Americans get a tax credit to purchase coverage. And so if you are in a situation where your employer does not offer coverage, you're not eligible for Medicare or for Medicaid or for CHIP, the ACA provide a marketplace where anyone can go and get individual health insurance coverage. And if you're at a certain income level, you get a tax credit to help you make your premiums and out-of-pocket costs more affordable. And so what we've seen over the last 10 years or so is an increase of enrollment in the ACA marketplace. Specifically, since about 2022, marketplace enrollment has increased from 12 million individuals to 24 million. And the reason why 24 million people are now covered in the marketplace is because of the enhanced premium tax credits. So when Congress did the ACA, it was the tax credit itself. But during the pandemic, President Biden and Democrats in Congress worked together to make that tax credit more generous and also expanded eligibility for the tax credit. And so what we've seen here is that that was a real game changer for millions of Americans. And so now we have 24 million people who are getting coverage, and almost all of them are getting that enhanced tax credit. The challenge we're facing, as Marvin noted, is that that individual, that enhanced portion of the tax credit that has helped so many millions of Americans, that portion is time limited and will go away at the end of the year unless Congress acts. So as we're thinking about what's at stake here, as Marvin noted, we're gonna have premiums that are gonna skyrocket. Families will, on average, see a premium increase around $10,000 per year. That is astronomical when you think about what is happening in our country right now from an economic perspective, cost and security. For a couple who is around age 60, their premium increase could be around $17,000, and it will vary state by state, but these are really significant numbers. And most notable, I think, is potential coverage loss. So estimates have ranged from 4 to 5 million individuals who will lose coverage, and particularly for communities of color, our estimates are at 3.7 million individuals will lose coverage. It will simply become unaffordable. So as we're thinking about all of the challenges that we're facing and we're going to discuss today, ensuring that the tax credit's able to get extended is absolutely critical for our nation.
Great, thank you. And Dr. Cochran-McClain, comment was made about potential loss of coverage. Rural communities face unique challenges to begin with. Can you talk about what those challenges are? And then what does it mean for coverage to go away in these places?
Absolutely. Thanks, Marvin. And you can call me Carrie. So hi, everybody. It's great to be with you this morning. Again, I'm from the National Rural Health Association, and our organization really tries to be a voice for rural healthcare at the national level, representing patients, providers, community-based organizations, academic organizations. Anyone who has an interest in rural health has a home at NRHA. And you're right, Marvin, we in rural America, individuals have much more reliance on public payers, so Medicare, Medicaid, marketplaces. And as we think about these pending cuts to these programs, there will be a disproportionate impact on our rural communities, the individuals who live there and the providers who care for them. So if we think about just breaking down those numbers a little bit, Craig talked a little bit about some of the percentages with Medicaid. We've got about 40% of the kids in rural parts of this country are covered by Medicaid. 50% of the births in rural areas are Medicaid, and about 20% of adults. So it is a significant source of care and coverage. We also, in the marketplace, see similar numbers. For lots of reasons, health insurance costs more in rural communities, and so our populations have really benefited from not only the marketplace, but the enhanced subsidies. And if you look at numbers, we've got about 28% higher percentage of folks in rural areas who are having increased savings to their premiums and their coverage thanks to the marketplace. So it plays a really important role. And part of that is because if you think about our rural communities, we have fewer job opportunities. There tends to be folks with lower incomes and more self-employed or smaller businesses that may not have the opportunity to offer employer-sponsored insurance in the same way. And so when you think about what Medicaid and what EPTCs or the premium tax credits have brought, they really allow rural populations to have savings on premiums and more kind of zero premium plans. And this is all really important when we think about rural communities, because in addition to kind of having, unfortunately, some of those lower incomes, fewer job opportunities, we have a tough population to serve as healthcare providers. We see more preventable premature deaths in our rural communities. And that, I think one statistic that always kind of floors me when I think about this is in 1999, our mortality rates or death rates in rural areas was 7% higher in urban. You fast forward to 2019 and it was 20% higher. So our populations who live in our rural communities, just, if anything, we should be investing more, not thinking about how we cut their access. And when you think about that coverage piece, and I promise I'm almost done. I could go on all day here. But when you think about that coverage piece, the other part of this that I don't know that everyone connects the dot is that, you have an individual who's got, let's say a coverage through the marketplace, or you've got coverage through Medicaid. These are your neighbors, the folks you run into at the grocery store, the folks you go to church with. The providers in those communities are going to continue to see those individuals when they lose their coverage, and they're paying out of pocket, and they're doing the best they can to pay their provider at the end of the day. And so that impact of losing coverage, we think about the individual, but it has such a rippling effect across the entire rural healthcare infrastructure. And that infrastructure cannot stand further strain. I can spend a lot of time talking about that too, but we've had 190 hospitals close or discontinue inpatient services, meaning they're not providing care like you think of a hospital, since 2010, in the last 15 years. And the financial status does not look good there. And so cuts, again, will not only disproportionately impact those individuals who are covered by Medicaid and Marketplace, but the providers and everyone else who goes to seek care from those providers.
Great, thank you for that. That's a good segue. Dr. Khatri, you're on the front lines of delivering care. What does it look like when Marketplace and Medicaid instability shows up in a patient's life?
Yeah, so thank you, and I'm honored to be here. I am representing a community health center, FQHC, for those of you who are more familiar with the 330 statute. But so community health centers really were started as part of the civil rights movement, and they had a very clear charge to provide care to everyone regardless of ability to pay. That's our mission, that is our charge. So you're absolutely right, Carrie. We see everybody. We are also patient run. So by statute, 51% or more of our board members have to be our patients. I tell our patients, you're my boss. You own this organization. And so for us in Tennessee, we have really a broad reach of 25 counties we serve. Most of our sites are in rural areas, but we also have sites in inner city, Chattanooga, and in Knoxville. We have 21 brick and mortar clinics, 2 mobile clinics, and 25 plus telehealth sites. So for us, Tennessee did not expand Medicaid. I tell this to everybody, and they're like, what does that mean? Okay, let me tell you what this means. Right now, if I look back at 2024, 25% of our patients have no insurance. 25%. At the height of the pandemic, it was 30%. And I have a distinct memory of the first wave of layoffs. If you remember in the beginning of the pandemic, all these people got laid off from their jobs. They lost their health insurance. All their practices that they were going to literally had on their website, go to Cherokee Health Systems, or that was part of, if you've lost your health insurance. So, just here's where you go, here's the number. I have a memory looking out my window and seeing a line of people. This was people who worked at coffee shops, at the grocery stores, people who worked at every sector, showed up and they say, I can't, I'm gonna die if I don't get my insulin, if I don't get my medicine, etc. So 25% of our patients are uninsured, 40% have Medicaid, which is in 10 care. Every state has their own name, it's our 10 care. And then 22% are commercial. The vast majority of those 22% are the marketplace plans. So from our perspective as a provider, yes, we have a charge to see everyone, but they're regardless of ability to pay. But it is not sustainable or scalable for us to continue with this 25%. And I'm going to tell you this, if these marketplace credits go away, if there is further contraction in coverage, a lot of people not only will lose their health insurance, they will not be able to work They'll not be able to get the access they need to care, to medications. We have many, many people, the reason they're able to be productive and do things that they enjoy and engage in activities is because they have the care that they need. So for us, here's the issue. Yes, and I've heard people say in the room with me, yeah, we know you're going to see them anyway. What's the big deal? Listen, there is not some, magic fairy dust or fairy godmother sitting behind me saying, well, when one thing goes away, here's all this extra resources. We have community health centers and practices across the country that are one payroll from going under. One payroll. When there was a brief period of time where the payment management system for grant funding through HHS was frozen for a week, and we were fortunate, we've got some savings, but I talked to CEOs at 3 community health centers in Tennessee who said we have one payroll left. And there were community health centers who let people go. So the damage is much more dramatic and much more multifactorial than you can imagine. So the second point is you're going to have more people who are uninsured, and here are the ripple effects. People will go without care. We ask people who come to us, we have walk-in clinics, what would you do if you hadn't come here today? 70% of them say, I would have gone to the ER, or I would have not gone care, and when it got really bad, I would have gone to the ER. So the health issues, the other concerns are not going to just go away. The final point I will make is, for many of us who are community safety net providers, we don't just provide care. Every one of our sites has a food pantry. In the clinic in which I work, I still see patients. We give away 13,000 pounds of food a month. 40% of those recipients are kids under age 17. We provide transportation. We provide vocational rehab, career support for people who want to go back to work, particularly if they've had chronic mental health issues. We are a learning organization. We train physicians, psychologists, clinical social workers, nutritionists, pharmacists, nurses, nurse practitioners. We do that because we have built an infrastructure. So the impact is not just in one area. The impact is going to be at a much broader scale and a much deeper scale. So for us, this is a game-changing make or break time, and it's absolutely critical that we take action.
Thank you for that. And Craig, Dr. Khatri mentioned expansion. So there are a couple of states that have not expanded Medicaid, including Tennessee, but also Florida and Texas, that I read somewhere that if they expand, it will significantly reduce health disparities. Can you talk a little bit about expansion and what does it mean for racial disparities persisting and being removed?
Well, wow, a whole 20, another 45 minutes. Yes,
you have
there are
3 seconds.
3 seconds. See me after. So the way the Affordable Care Act worked was they expanded Medicaid. The federal government said, we're going to encourage states, actually they thought they were mandating it, but they said we're going to encourage states to expand Medicaid up to this level, and we're going to pay 90% of the cost to make sure every state does it. And then the tax credits kick in, and the marketplace kicks in with subsidies from there. So we could have coverage across the spectrum.
It's like a layer cake.
Like a layer cake. And so, so the Medicaid portion was the base. But then the Supreme Court came back and said, it's kind of optional. And a lot of states said, we're not doing it. It's called Obamacare. We're not doing it. And what that ended up doing is it ends up leaving, I think it's about 4.5 million people without insurance that should be on Medicaid within the states that chose not to expand Medicaid. Less than 10 states, just happen to be a couple of them here, so just less than 10 states. But those states, and you mentioned 2, Florida and Texas. Of the 4.5 million, half of the uninsured that would be insured through a Medicaid expansion are in those 2 states.
Wow.
And so you have 2 states that would have millions more people insured through Medicaid. They can't qualify for the subsidies. They don't qualify for the exchange because Congress had assumed they would be on Medicaid. So there's really a hole. There's this hole where people are uninsured. Mention that. So, and what happens is, and I just want to make this real clear for folks, when you're uninsured, there is an operational side to it, but there's a personal side to being uninsured. And what that means in this country is that, I'm just going to give you a statistic here, the number 1 cause of personal bankruptcy in this country remains healthcare. Medical debt. The number 1 cause. There is a direct correlation between Medicaid expansion and personal bankruptcies in this country. That's fascinating to me. It says you are forcing people into bankruptcy, is what that means. She spoke about the choice of, can I wait until I go to the emergency room? What happens is you become bankrupt in this country if you don't have coverage. That's what it means. And it's a direct correlation. You can look at the map of the country, you can look at Medicaid expansion, and you can map it to personal bankruptcies in this country. It's fascinating.
Carrie, you mentioned the unique challenges of living in rural America. Can I get you to zoom in a little bit? Living in rural America and being Black.
Yeah. Can I just add on to Craig's point real quick? Of that population that is in the unexpanded states, 2/3 of the rural population are in unexpanded states. So again, you've got a disproportionate impact. And if you think about the map, and I'm terrible with geography, so I can't do like the hands to make the United States play.
Like
but,
Michigan?
If you think about the map, where we have significant numbers of folks who are in non-expansion states, where we have our hospitals and other rural healthcare providers that are struggling the most, either financially vulnerable or have closed, it is in the south and southeast parts of this country. So there is, again, a disproportionate impact on certain populations. And there is a definite intersection between race, geography, and income in certain parts of our country. I think when people think rural America, a lot of folks think the image that comes to mind is like a white male farmer, right? But it's so much more diverse than that. A quarter of our populations living in rural are racial or ethnic minority. So we have a very diverse population. We've got, of that kind of 24%, 9% are Hispanic, about 8% are Black, and about 2.5% are Alaska Native or American Indian. And when we look at kind of these issues of how the data spreads out across the country, it's not equal, right? We have so many of our rural providers who are in counties where 80-90% of who they are caring for are on Medicaid. And again, there are disproportionate impacts on certain populations as we think about these policy cuts that are being debated in Congress.
And Lauren, the debate in Congress on enhanced tax credits, where is it going right now? What's the status of it?
It's a great question. So one of the challenges we're facing right now, and I feel like this is the understatement of the year, is that it's a little bit hard to break through. As you can imagine, there's so much happening. And when Congress is focusing on tax cuts and unfortunately cuts to Medicaid, the enhanced tax credit piece is getting a little bit of attention, but not as much as it needs to. And I think one of the challenges we're facing right now is that as Congress is moving forward on their reconciliation package and all of the changes they are making, and unfortunately potential cuts to Medicaid, those are proactive things that Congress will be doing. Whereas on the tax credits, unless Congress acts, the tax credits go away. And so it's a little bit of, you don't want Congress to act on Medicaid cuts, but at the same time, we need them to act to extend the tax credits. And so that's one of the challenges we're facing. But I will say we have phenomenal champions in Congress. We have Senator Shaheen and Senator Murkowski, who's Republican from Alaska, in the Senate, who are championing this issue in the Senate. And in the House, we have Congresswoman Lauren Underwood, who is fantastic. And so she is championing this issue in the House. And so what we've seen, though, is that on the Senate, there is a little bit more of a bipartisan discussion happening. I think that there's a recognition of what's at stake for patients if the tax credits go away. The challenge right now really is the timing. Because yes, the tax credits are in place through the end of the year, but the reality is that as open enrollment approaches in the fall, if Congress does not extend the tax credits until the end of the year, we're already past open enrollment. And so people's premiums will already be skyrocketing. And so when they're going to purchase coverage in October and November, it's going to be sticker shock. And so that is one of the challenges we're facing, is getting Congress to act fast enough so that way the reductions can be put in place as bids are being put together and plans are putting together their options for plan year 2026.
So consumer goes into the marketplace, sees that there's higher premiums. What does that consumer usually do, or likely to do?
They're likely to forego coverage, which is a really big challenge. I mean, we've talked about just what's happening right now in health equity and just the consequences of inaction, particularly from a cost perspective. And so people are going to look at their premiums and what is being offered and say, I can't do this. And that's going to leave them uninsured and going back to FQHCs, which is really just not a great place to be at all for anyone.
So person doesn't have coverage, needs care, goes to FQHC. Can you say no?
Well, we can't. We will do our best not to say no, but the reality is that you can't make something that's not there. Health centers closed during that one period of time where they could not access their grant funding. So there is no limitless pot of resources for FQHCs. The other thing I just want to point out is community health centers offer incredible care. FQHCs have the highest standards of care. If you look at the research, we save the healthcare system $24 billion a year. And because we keep people out of the hospital, we keep people off expensive meds. We report about 60 clinical quality metrics. Most private practices don't do that, but you can go online and look at every community health center and see what's our percentage of patients who manage hypertension, what's our percentage of patients who are well controlled for diabetes. And for us, I have to say, we've worked hard. At Cherokee Health Systems, we have for like 7 years in a row, been a national quality leader, which means we're either in the top 10% or top quartile. And that's a pretty big deal, particularly when you haven't expanded Medicaid. The reason I say this is we have a charge to serve everyone, but when we're looking at different people who have Medicare, particularly in rural communities, we're in communities where there is no provider. No one's going to go to White Pine, I know, because a mayor comes to us and said, you know, we have an entire community here, 1,100 seniors. There's nowhere for them to go within 20 minutes. They're going to have to go 2 hours to get care. Can you open up a clinic? When we are stretched thin and thin and thin, right now I can say yes. But there will be a time, potentially, where I'll say, I'm really sorry. We can't do it. We cannot open in White Pine. We cannot open in Greenback, which is another place where we're looking. 1,100 people in this entire community. They're all spread out. And more and more, those are becoming manufacturing areas. So we are in rural areas. They're building manufacturing factories that they're not offering healthcare coverage. They need us to come in and provide urgent care. But the reality is that we have to say no because we don't have it. And it's not just saying no to uninsured. This means people with Medicare, people with commercial, people with Medicaid, across the board, there's going to be contraction in our ability to offer care. And you're not just pulling away a safety net clinic, you're pulling away some of the best health care that is out there. And that's what everyone in our community deserves. High quality, safe, equitable health care.
And if I could just add one point, I think the other thing here that's really critical is people are going to forgo their preventative screenings. They're going to forgo going to see the doctor. They're going to forgo going to see the dentist. And so all of these issues are going to compound the community, and we're going to have a sicker population. We actually announced our second ad this morning, where we have a patient named Kenny who has a blood disease, and he's on the ACA marketplace in North Carolina, and he has an enhanced tax credit. And he, in our advertising, really talks about from a patient perspective, what the tax credit means. And at the end, when we interviewed him, Kenny stood up and he said, the tax credit makes life possible, and health insurance makes life possible. And that's really what's at stake for patients across the country for all of these issues.
Great.
Yeah.
Thank you for
Marvin,
that story.
If I could build off of that too, I mean, I think the other part that's so frustrating about this conversation, if you're listening to folks talk on the Hill about the Medicaid cuts, is, there is a line that you'll hear that says, protect our traditional Medicaid population, which is code for non-expansion and who knows whatever else. I try to be a little bit nonpartisan in my comments, but I think what is so hard about that is when these providers, and I'm going to talk about in rural communities, when they start to feel the financial strain, they have to make really tough choices. And one of the really, I will say, epidemics that we are seeing, or crises that we are seeing across rural America right now, is the closure of obstetric care.
Yep.
We have over 60% of our rural areas in this country no longer offer obstetric services. Obstetric services, believe it or not, are optional services to hospitals. They are loss leaders kind of across the board. And Medicaid, close your ears, Craig, Medicaid tends to pay half or less of what commercial payers pay for births. But we have at least half of our births in most rural areas are Medicaid. So when you start doing the math at the end of the day, and you have a service that is a loss leader, and you start to lose financial resource other places, you have to make tough choices, and obstetric care is one of those places. And if you're a woman with means in a rural community, you can go outside of your community for labor and delivery, for prenatal and postpartum care. But if you don't have those resources, if you are a working mom at home with kids and you can't go 2 hours to get your OB care, what options do you have? And so, it's closure of facilities, but it is, again, the rippling effect of these discussions is so much more than what's being portrayed in some of the conversations. And we really need, to the extent that you end up talking to folks on the Hill, it's so important that full picture is really communicated. And you talk about kind of what that means to people who have employer-sponsored coverage, who are on Medicare. Those services go away for those folks too, when hospitals, who are 53% of hospitals in non-expansion states operate with negative margins, meaning at the end of the year, they have negative operating margins. And there's only so long you can do that. And there's only so many cuts you can take before you have to start closing services or closing altogether.
And so we talked about the marketplace, and then I alluded to Medicaid and the conversations that are happening in Congress right now. But I want to make it more explicit, Craig. Can you talk about what are the discussion happening right now in Congress about Medicaid?
Yeah. Yes, I can. But can I start with one comment, which is, if Tennessee expanded Medicaid, you could make it to those communities, right?
For sure.
You could be in those communities.
We are doing it right now, but I don't know if we could in a year from now.
But if they expanded Medicaid,
absolutely,
you'd be in a whole different place.
Game changer.
And of the states, when it was originally come up, Medicaid expansion, a lot of states said no. There's still some states that are still saying no. But every single ballot measure that sought to expand Medicaid passed. Think about that for a minute. Every single in every color of state, mainly red, because those are the ones that chose not to expand Medicaid to begin with. Every single ballot measure to expand Medicaid, South Dakota, Missouri, hard red states, all passed. Medicaid is a popular program. So let's change let me answer the question that you had, which is Congress right now is debating, the House put in an $880 billion savings goal within the committee that Representative Kelly sits in. That was when she said, I get to go back into this. Thank you.
She does not support.
Yeah.
No.
Thank God we have her sitting there,
Right.
which is that she gets to have that voice too in the committee while it's happening. But that may be happening within the next week. Next week, the Energy and Commerce Committee is set to have a markup on this topic. Meet that $880 billion savings goal. Largely within their jurisdiction, it's just the Medicaid program that can get there from here. $880 billion is a big number. Let me give you an example of how big
Can I pause
that
you real
is.
quick?
Yes.
Savings is very DC speak. What does savings mean?
Mm-hmm.
What does it mean to find $880 billion worth of savings?
It means that they have extrapolated how much they think they're going to spend, and they need to cut $880 billion out of that spending over 10 years.
So it's an $880 billion cut.
Cut over a 10-year window. But let me tell you what that means. I know these numbers, we talk about billions and trillions here in this city, but $880 billion is about what the federal government spends on Medicaid each year. It's about $800 billion. So, just in real terms, if you cut $880 billion out of Medicaid over the next 10 years, you could do it one way, no Medicaid for 1 year. It's the same thing, right? Pick a year of the next 10. Dr. Cochran spoke about the next 25. Think of the next 10. Which year do you pick that we're not going to have Medicaid? That will achieve the savings goal. That's crazy to me. That's how much money they're looking to save within this program. Just eliminate the program for 1 year. Wow. Right? That's the impact.
Can I just add something? And I think you made a good point, that savings is not fully accurate, because you can cut.
Oh, yes.
You can cut, but I'm not quite sure you're really creating the savings that you think you're creating, because there is a cost. There's a cost, and there's going to be an economic cost. There's, frankly, a moral cost.
Personal.
There's a social cost, and there is a political cost. So you can say, I'm going to cut. It's like, I'm not going to put gas in my car this week. I've saved $40. Well, you can't go anywhere.
You lost your job. You lost your job.
You're going to lose your job.
Yeah, you lost your
right?
job.
You will probably get depressed because you're looking at four walls that you're not going to be able to get food. So savings, this is why it's important. It's a cut. I'm not quite sure it's a savings in any way if you look at the overall picture of the budget.
Great. You know it's getting good when people say, Carrie, come back into the conversation. So what does these cuts mean for disabled Americans? What does it mean for nursing homes in rural communities? What does it mean for the system in rural communities if these cuts go into effect?
Right. So I've thrown some numbers at you all, but again, just talking about the number of rural hospitals that have closed or discontinued inpatient care in the last 15 years, we've got 190 of those. We've got nearly half of rural hospitals overall in the country operating with negative margins. We've got another 432 that are vulnerable to closures. And I've talked a lot about rural hospitals because that's where we have access to data. But these trends are the same across long-term care, Marvin, that you mentioned, so skilled nursing facilities, around independent pharmacies, around independent physician offices. So the rural healthcare infrastructure in many parts of this country, and again, I'm giving you national numbers, but this looks very concentrated in certain parts of the country. And if I had my maps up here, you would see all the dark red, meaning the hot spots, the most vulnerable. I hate to say it, it is so many of them are in the south and southeast parts of this country. They are the healthcare infrastructure there is hanging on by a thread. I will reiterate that you start to cut around the margins, not even $880 billion, but let's say they do a small piece of that, or let's say the marketplace enhanced tax credits don't go through and people are going without coverage. Those numbers very quickly add up. that you will see. I actually am not sure how we get through the next year of conversation, whether it's Medicaid or the marketplaces, without having some kind of effect of closures or service loss in rural communities. Because like I said earlier, we need to be expanding, we need to be supporting these folks even more, and we're going the wrong way. And we haven't even started talking about what's happening in the administration and the proposed cuts that are happening there, and I won't take us down that path, but it's not like anybody's wrapping around on the other side to make sure that these programs, whether it's health centers or rural hospitals, are getting kind of the support they need at the end of the day.
Great. And we'll be taking some audience questions shortly, but Lauren, what does it mean for a healthcare system if the enhanced tax credits go away?
I mean, we talked, I think, a lot about this morning. I mean, it really is, for the healthcare system, we're going to have patients who are going to forego care. They're going to forego their preventative screenings. They're not going to be able to afford going to see their physician or afford their medications. And for the healthcare community broadly, we're going to see closures, and we're going to see just a reduction in access to care and the ability of providers to offer that care. So the consequences are just catastrophic across the board. And then you compound it with the conversation around Medicaid. You know, you can't look at these issues in a siloed way. And so when you're talking about a double, whammy of potential reductions in Medicaid, along with the tax credits potentially not getting extended, you can't underscore enough what the consequences will be for patients and communities.
Great.
And building, one other thing on Parinda's earlier point. So, in rural communities in particular, a healthcare provider tends to be one of, if not the largest employer. Mm-hmm. So there is, again, a rippling effect of these decisions where you lose your hospital or your healthcare provider. Not only do you lose the major or one of the major employers in the community, you lose your ability to attract business. No new business is going to want to come to a rural area or a community where you can't offer, basic healthcare to your employees. And again, this is when you think about these cuts. It is to healthcare, but you are talking about cutting underserved and vulnerable communities across the country when you're talking about this.
Thank you. And microphones are set up if folks have any questions for our panelists. Go ahead and start making a line. I think we have one person. All right, we'll just start over this way then.
Good morning. Thank you so much. Danielle Gilliam with Novo Nordisk. I have a question in regards to the comment that you made about rural America. And one thing that stuck with me was when you say, when you think of rural America, you think of, a white male farmer. Mm-hmm. I believe the problem behind why people don't vote in their best interest is because their imaging looks different. Everyone up there said that Medicaid has a different name in their state. And so when you talk publicly about Medicaid's getting cut, they don't think that's happening to them. Mm-hmm. What is happening in your particular organizations to increase this? So this all falls under health literacy. We think it's just making people understand what the big doctor terms means. It's not. It's things like this where maybe we wouldn't be in the situation we're in now if people really knew that when they were voting, this is what that meant for them. Because right now, Medicaid and DEI looks like the single unwed Black mother with children, and that's not the case. So I'd like to hear your response to that.
Craig, do you want to?
Yeah, I'm going to take a crack at it. Longer discussion.
Now you have 45 minutes.
Yeah, and now I got 45 minutes. To be honest with you, I think a lot of folks spent a long time trying to get Medicaid branded as something else. They worked on that. That was intentional. That's an intentional look about Medicaid. It's not, you don't get a card from your state. You get a card from a private health insurance company. You get something else that doesn't say Medicaid on it. It doesn't say you're insured by the state of Vermont. It doesn't say that you're insured through the state of Tennessee. They intentionally did that so that folks said, oh, look, I'm not, to use the term, I'm not on welfare, right? You remember how bad that word was in 94, right? Which was welfare reform. We need to get people off of these things. It's still there, but they intentionally rebranded it that. And this is kind of the other side of that, which is now you've rebranded it, now you don't realize where it came from, right? So you rebranded it so it wasn't government-sponsored health care. That's on purpose. And now you're like, you don't even know how it's funded. So you're fighting an intentional discussion, which was, I was trying to get you a private insurance card. Now let me go back to the other discussion, which was Medicaid was originally set up to be a marginal payer, which meant you serve 100 people. If you serve one more, how much does it cost? It's not supposed to be the bedrock of the entire foundation. It's supposed to be one more person. It's actually supposed to be the payer of last resort. Is how it was phrased in the very beginning. It's supposed to be the marginal payer of last resort. And that's the legacy that even you heard of from the beginning of this panel before this, which was fighting a legacy of injustice within this country, right? Which was, I'm going to make it a marginal payment. I'm going to make it the worst thing. I'm going to make it only for this, and it's going to come through these folks. We have tried to move it away from that. But it's an intentional move away, but you're exactly right. It changes that branding it changes the advocacy arm of it. But to be fair, Medicaid expansion, extremely popular in this country. And I would say that if it came up as a ballot measure, some states, the states where it hasn't expanded, the Floridas and the Texas, you can't do it by ballot measure, right? They don't have ballot measures. I'm from Oregon. We believe in ballot measures. We ballot measure everything. But so the states say, no, we're not going to listen. We're not going to do that. So that's how you have Medicaid not being expanded. But I think you're exactly right. But it's even an intentional challenge.
Yeah. Thank you.
Yes, my name is Bruce Taylor. I'm a patient advocate. And one of the questions I've got is that when you look at this $880 billion, I've got 5 grandchildren. I'm trying to teach them modern math. Does anybody have government math for dummies? Because I appreciate it. Yeah. Is it a cut? Is it a savings? Yeah. But I don't think we've really gotten into, if you're a state legislator, and all of a sudden you're trying to get your balanced budget, which you have to do statutorily on a biannual basis. I live in Indiana. They're about ready to pass the budget. The bean counters came in. We're $2 billion with the B dollars short. So there was this last end scramble trying to do that. Well, when your tax dollars go down, there's only 4 levers that you can do as a state legislator. You can cut professional reimbursements. Well, right now, when you treat a Medicaid patient, you're underwater. Yep. So you want me to, I know enough about business to understand if you lose something on a transaction, you're not going to make it up in volume. It just doesn't work. 2, you can limit the benefit of Medicaid. You can change the eligibility criteria. 3, you can start cutting benefits. And the expensive benefits usually go to people with chronic conditions. If you're not managing chronic conditions, then it's going to come back, and they're coming back they're going to the hospital. The billions of dollars that you saved in Tennessee are real. Hospitals are ungodly expensive. The 4th one is just eliminating benefits. So we talk about the $800 billion with this new math here in Washington. We got to really start looking at the math of what's going to happen in Tennessee or what's going to happen in Oregon, because those state legislators are at gunpoint right now. How do I make our budget work?
I think that's a standalone comment, right? I think that's very true. Craig, I'm happy to let you come in, but let's let Craig talk.
Something on my face says that. So, 2 things. States have a mandatory balanced budget. The largest source of funding transfer between the federal government and states, Medicaid. It's the largest source of funding from the federal government to the states. So when your state, exactly what you said, has a challenge, the largest source of funding coming from the federal government is Medicaid. I would only argue with the 4 points. You could also do it better. Yeah. That's what we try to do, right? All of us up here. You could do it better. And there are ways to do that. Longer conversation.
Well, and I'll just say, Tennessee has actually financially been in a really good position.
Yet didn't expand Medicaid.
It didn't. So actually there are, it's billions of dollars of shared savings. Our rainy day fund has gone up even more. They're very, very proud of it. Yet they're struggling with the healthcare issue and the education issue. But even this year, when they passed the budget, and I'm not saying it's going to be that way in the future, but they have a lot of money in Tennessee. It's just not going into healthcare.
Yep. We have another question here.
Yes, Angela Moore from North Carolina A&T State University. What can be done to force healthcare institutions to work with federally qualified healthcare centers? When you talk about trust, most federally qualified healthcare centers have the trust of the community.
Yes.
Yet you have academic institutions, healthcare entities that receive, you have individuals within a 5 to 10 mile radius of those institutions cannot get into the door of those institutions. And then you have them fighting and trying to take away some of the patient populations from the federally qualified healthcare centers, especially when Medicaid expansions come around. It's all about dollars, not necessarily helping the patients who need it the most, but it seems to be this push and pull. Yeah. We have the resources, so we'll offer certain things. However, it's not consistent.
Right.
And so how do we get federally qualified healthcare centers to partner, academic institutions or healthcare entities to partner with federally qualified healthcare centers to have more sustainable care for our communities?
Okay. I'm trying to think how I can say this. Most academic medical institutions have two main, they're organized into two different entities. One is the academic, which is the Graduate School of Medicine. That is the state funded, or they've got some federal funding, but that's that. Then there is the practice arm, which is very often a for-profit entity, and they are run like a wealthy private practice. And so many of the medical providers, healthcare providers who work in an academic health institution get two paychecks. They get one to be a professor or to teach, and then they get another, which is the big paycheck, which is the practice arm. And so when I speak with our local academic medical centers, they are very happy to give our patients infusion centers, do surgery, procedures, diagnostics. They love the diagnostics. They do not want to see our uninsured patients. Trust me, even last Monday I met with CEOs, and it's just, don't get me started on GME, please do not. But the issue is that this is for many parts of the healthcare sector, this is about commerce and it's profit. For community health centers, we're nonprofit. We're like, this is about our mission. And so when you don't have alignment, we are not going to partner with you. We are not going to let you take advantage of our patients. You cannot do that. And you have to give something back. So we train physicians, nurses, psychologists from these places. We don't get paid to block our schedules to train. And in fact, we have to pay a pediatrician to go, we pay her salary, and she goes for free to the academic medical center to do grand rounds for them. And again, it's not all that these people are bad or these people are good. There is this tension between the education and academic component and the for-profit practice management where they're running it. And I'm adding a third group in there, which has exploded in the last several years, and that is venture capital, private equity. Most anesthesia groups now, GI groups, they're all owned by private equity firms. So it has changed. It is a business. And so you have to have, in order to be good partners, you have to have at least some overlap in mission, values, and that's not there consistently because of this tension that you have often in academic medicine.
Thank you for that. And running against time, before we step down, I want to be able to do a quick lightning round. What should people know and what should people do based on the information that they just received?
Yeah, well, I want to build off the comment here in the front about health literacy. I think it's on all of us to be having the conversations with people who are living in our communities and the lawmakers and policymakers who represent them, so that they understand and can put a face to the conversation and loss of coverage that we're talking about here. It's understanding that ripple effect, and it's going to take all of our voices to help make that happen.
And I'll pick up where Carrie left off. Use your voice. Your voice is powerful. Members of Congress, elected officials, pay attention when they're hearing directly from people in their community. And please, 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 as you're talking about healthcare issues and what's at stake, it's Medicaid, but it's also the tax credit piece. And so we need to make sure that we're talking about both and what the compounding effect of these changes will have in our communities.
Dr. Carrie.
I would just say yes, and focus on the consequences of, if you do this, what is going to happen? Because right now, many times people aren't thinking about that. It looks so sexy and good. Let's cut $1 trillion. Let's do this. And then what? And then what? So help them think through beyond this next budget cycle.
Bring us home, Craig.
Make it personal. You know somebody on Medicaid. Make it personal. All the stuff, all the $880 billion of this and the hospital that and this, yes, that's important. But when you tell your story, that's the most important.
Great. Thank you all for being a great audience.